very useful, but buys you some time because it has a lower viscosity than room air or oxygen alone, and so can get through narrow spaces relatively more easily. If you are in need of CPAP, then that needs to be put on by a skilled practitioner of CPAP. But Thrive, which is now more widely available in ITUs and in theatres, is a very good and useful way of oxygenating a patient through high flow nasal oxygen. The flows are much, much higher than what we're used to, not 15 litres, but maybe even 75 litres a minute. And I've had patients maintained on an apnea with full muscle paralysis for at least an hour to an hour and a half. Those are patients that have a low BMI and various other factors which allow them to tolerate that. But you can still temporize a patient with Thrive and buy yourself some time, especially if they are still making some respiratory effort. If you're then going down the path of a face mask and bag, then maybe a pharyngeal or nasopharyngeal airway may be helpful. And then you're going into the realms of interventions of various sorts. And whether you decide to use a laryngeal mask or some form of transcutaneous approach to the trachea, probably the one that might be the easiest is a cricothyroid membrane puncture using a wide bore cannula. Whether you do that depends on your skill, but it might buy you some time, especially if you have no other equipment to hand. If you're now getting to the position where you're going to have to get someone to intubate them, you may then decide that surgery can actually improve the airway obstruction. And if there's, for example, a tumor in the larynx, then once you have a tube down, you may decide, rather than going on to a tracheostomy, but you might just simply remove a certain amount of the disease, or even debulk or do a hemilaryngectomy and give them a reasonable airway, and also get tissue diagnosis. And I've written this up quite a few years ago. Up until recently, we hardly ever did tracheostomies for patients with with large tumors in their airway. The more standard indications for tracheostomy we are all probably familiar with. We are all surgeons, and so we probably know that surgical tracheostomies are done for all those reasons that I've listed, and I'll go through them very briefly. The main one is to obtain an airway and to maintain that airway. And if patients are being ventilated on the unit, they do need a surgical airway if they're going to be on the unit for more than 7 days. This figure was reached out from various studies, and it's been shown to help reduce the risk of long-term laryngotracheal disease and stenosis as a result of intubation. Other reasons for performing a trache: if the patient doesn't need ventilation but is producing copious secretions, then access to the airway and lavage and suction can be very effective through a small trache. Protection of the airway needs to be discussed in a multidisciplinary environment before doing so. I don't believe that tracheostomies will protect an airway if somebody is aspirating, and it's probably better to try alternative techniques, but it is still cited as one of the reasons for performing a trache. When we're doing major head and neck resections, sometimes we are putting in muscle flaps into the oropharynx, and so as part of that procedure, one would do a tracheostomy to temporarily maintain the airway, and then once the swelling has subsided, remove the trache. And then finally, in order to help patients get off of ventilators, there are various mechanisms that are cited as helping patients to be able to get off of ventilators, such as a reduction in the dead space, the reduced requirement for sedation and paralysis. So such patients, when they are able to spontaneously breathe, they may not be able to breathe fully for perhaps more than an hour, but at least then they are easily pluggable back onto a ventilator through a trache, whereas a larger number of patients probably are intolerable of an endotracheal tube and doing it through that route. What is it about the tracheostomy that we need to be particularly focused on when we're doing a standard trache? Firstly is obviously the landmarks and getting the patient in the right position. So we know that the patient should be extended on the table with the head extended and a shoulder roll under the shoulders. and this brings the trachea close to the skin. You can then palpate all of the usual landmarks. And if you're a novice, you would start from the chin or symphysis menti, working your way down to the sternal notch. And so ideally feeling for the hyoid, the thyroid prominence, and then the cricoid. And the cricoid is the key because below that is where you'd aim for an incision. The cricoid is also very easily palpable and will help you to count down to the third or fourth tracheal ring in hopefully a slim neck so that the fenestra can be put in at the right level away from the cricoid cartilage. Before doing so, and before making any fenestras, you need to check your equipment when you're doing such procedures. I will go through this in slightly more detail because there are variations on this from where you do this procedure in a COVID patient. So obviously check the equipment that you have, that the trachea tube has a functional cuff, that you have the appropriate anesthetic connecting equipment. You warn your anesthetic colleague that you're about to make a hole so they can move the endotracheal tube and deflate the cuff. And then you make your hole in the trachea and put the tube in by getting the anesthetist to withdraw their tube first. And then you can secure the trachea tube in the correct position. And the idea for this is to firstly suture secure it in those patients where they may perhaps be a little more rowdy if they were to wake up, or if you are worried about their airway being very precarious, then you would still secure it with sutures. But taping should be done with the head in the neutral position because the trachea then distends away from the skin of the neck. And that theoretically means that the tapes that you put in when the patient has their head extended will become loose when you flex the head. I'm not going to talk a great deal about pediatric trachees, but there are probably other talks that are done at a higher level. But the essential difference is that we do not cut windows into the child's trachea, partly because their tracheas are usually more cartilaginous and softer. So a vertical slit through maybe 2 or even 3 tracheal rings is usually enough. But because you're making a vertical slit, you need to put 2 stay sutures either side of that vertical slit so that the tracheostomy tube changes are easier. Standard care for patients after their trachea should ensue. Remember that they will have a lot of blood going in the first 24 hours, so regular suction, humidification to prevent crusting, and periodic checking of cuff pressures and where possible, deflation of the cuff. So that's a very quick flick through of the tracheostomy, how you would normally do it. Now we are facing a slightly different situation in the current climate, and unless you're a hermit or have been asleep for a month, you'll know that we've been in the midst of the maelstrom of the COVID-19 crisis. Now this is a virus-driven condition, and the first thing to make note of is that this is a phospholipid membrane-lined virus, RNA virus. It accesses mammalian cells through some form of receptor, and it does have a propensity for knocking out patients who have previous comorbidities or perhaps the wrong ethnicity, and males, which means that I tick some of those boxes, which is not a good thing. But nonetheless, we are going to be called to help this group of patients with trachees, and we have to do so in a safe and sensible manner. And so the protocols that we drew up at the London hospital, which we then shared with many other colleagues, was designed to make this a pragmatic approach so that it's safe for us as well as the patients. Currently, there are no vaccines that we can rely on, and we also have tests which are not as reliable as we would like. So we have to presume whenever we do a trachea, anyone might have the disease and we should be careful. So these 2 terms have come up time and time again, and you should all know these terms, but I put them there just in case somebody doesn't know that PPE and AGPs are the 2 things that we focus heavily on because this is what we are faced with on a day-to-day basis. Key to this is the viral load. If we are exposed to a much higher viral load, it will give us a more severe infection. So we have to pick our patients and then also make sure we're properly protected. The procedures we do will be aerosol generating, and so we have to use every technique that we have available to minimize that and to reduce droplet transmission. Now, these patients are already in ITU, and they will have up to 60 times the viral load of an almost asymptomatic patient with very mild COVID disease. They will have varying degrees of respiratory distress. The stats may be low. Oxygen requirements could be high. They may have multi-organ involvement. There's a microvascular sort of coagulation that takes place, and this seems to knock out organs, either the kidneys or the liver, and others besides that. And they may also run into other complications. So these are very sick patients. So the aerosol generating procedures that we are going to be involved with are the airway procedures that we do, whether it's laryngoscopy or tracheostomy. And the types of aerosol that we create could either be droplets, they're usually heavy, and these droplets will be under the influence of gravity. So essentially, they don't have a long range and they will fall down eventually. Whereas the smaller particles that are true aerosols, they might be perhaps 5 or so microns in diameter, and they are able to float in the air. And so these are the ones that are the most difficult for us to manage. And those are the ones that we have to be very careful of. Now, these can remain airborne for a while, and it has been estimated maybe even up to 3 hours after a procedure. Now, that was with a very aerosol generating procedure in a patient that was not known to be COVID positive. So this is the figure that's been sort of cited of 3 hours. But we really don't know, so we have to take precautions for every patient. And what is PPE? Well, it depends on which environment you're in as to what you will be using. So if you are doing a clinic where you're simply talking to patients, maybe a face mask, being bare below the elbows, and having some eye cover might be enough with an apron, which are sort of more or less useless. But if you're doing an aerosol generating procedure, then I think you do need the full gown. Now, in China, they were using, on the bottom left of the screen, they were using these full body covering suits with a mask and eye protection. And they did that for all airway procedures, intubation essentially. We don't have access to that, but this is more or less what we have access to, which is the FFP3 mask, eye protection, and some sort of a hat, which is probably not worth much, and the visor on top with a sterile gown. There are other things that people are using across London. I know that at Imperial, they're using the PAPR system, which is essentially the isolating hood, which is connected through this little hose to a fan, which filters the air that's sent into the surgeon's sort of vicinity. This is one of the scrub nurses who failed her FFP3 fit testing, so she has to use this. I was given this at one of the local private hospitals when we first started doing our cancer surgery over there. And the problem with this is essentially an orthopedic surgeon hood, and it's designed to stop the surgeon contaminating items that might be implanted into sensitive areas of a patient. So they're really to protect the patient and the implant rather than the surgeon, because they're drawing in air from the theatre environment. So wearing this probably with this is a great thing, except as you can see, there is a big difference between my eyes and the microscope. So I had to take this off in order to do the procedure. So a complete waste of time. But you may be able to use this for tracheostomies. I don't think it's a good idea because you're taking in the theatre air. What is probably better is what we're using here, and it's much more practical and more probably widely available, because these are the orthopedic impervious hoods that we're all used to seeing them in. And you wear first your mask, your FFP3 mask. You then put the hood over your head so that it covers this mask, And then I had to put my glasses on and put goggles outside of that, and then the visor on top, and then an apron underneath. And then we go into theatres where we get scrubbed and put on our sterile impervious covers. And so we did our tracheostomies using this, and we managed to do 6 this week so far, with Mr. Ahmed doing 4 in one day and us doing 2 on that day. And it seemed to work reasonably well. So moving on to the actual indications for a COVID tracheostomy, we had a multidisciplinary approach to this, and we felt that in the end it's going to be the ICU consultants that are going to decide who is fit or appropriate for a trachea. But we felt that we had to protect theatre staff as well as the surgeons and the anaesthetist by insisting on a certain minimum. Firstly, we suggest that maybe a minimum of 10 to 14 days of ventilation before considering this, because many patients will make it and will get better, but an awful lot of these patients don't make it, unfortunately. And so some units I know at day 2 or 3 are offering PERC trachees to these patients, but that doesn't affect their overall morbidity and mortality, because these patients, if they're going to die from their multi-system disease, they will die, but with a trachea in place, with all the risks that are attached with performing a tracheostomy. In other words, a waste of time and effort and unnecessary risk for patient and staff alike. But that's me being unduly harsh, perhaps. Anyway, we've advised that perhaps a trial of first extubation first should be considered, but there may be a small group of patients for whom this is not appropriate if they have a grade 4 view of their larynx, if they have a fixed C-spine, and so on and so forth. We may have to just accommodate those patients by just doing a trachea up front. In other words, these guidelines can be bent to deal with the patient in front of you, and they're only guidelines. So use your intelligence and use your common sense and have a team approach. We felt that the patients should be on the road to recovery, falling inflammatory markers, reduced requirements for oxygenation, and their coagulation profile should be known, because many of these will be on anticoagulation because of that microvascular coagulation that goes on. We did talk about a chest X-ray for these patients just to work out where the endotracheal tube is, so we could work out how far to push it in for the technique that I'll describe, but we don't necessarily insist on this. What is the team? The team has to be the most experienced. So that means surgeon and anaesthetist. So if you have your usual scrub team, that's ideal, but you may or may not have access to them because they could be redeployed elsewhere. So in theatre, there's a skeletal staff and there's also skeletal amounts of equipment. So you have to think in advance of what you will need and ask for that to be available. And you have to have this concept of somebody in the clean room or anesthetic room as the clean runner, getting all the extra equipment that you don't have in theatre. And we also felt that you should have a second anaesthetist if you are doing more than one tracheostomy in a day, because these patients are usually needing a lot of support to be brought down to the theatre environment. And so having a second anaesthetist go off to get the next patient saves on time. So we should all be masked and gowned and be ready before the patient arrives in the theatre, because they'll be taken straight through to theatre. And you don partly in the corridor or wherever you're allowed to don, and then put on your sterile items in the theatre. We did talk about using a negative pressure side room, but the problem is a negative pressure side room is not really the au fait thing in theatres, because you're drawing in air from outside or from the rooms around theatre. And the places where you have that usually is ITU or the Royal Free, where I'm told that there are 2 negative pressure theatres. So we don't have access to those in most environments. So we just have to stick with the positive pressure theatres. And we felt that as most teams are familiar with theatres, that would be the best place to perform tracheostomy. We're all familiar with tracheostomy, we're surgeons, and I know that some groups are advocating PERCs. If that is your usual and standard practice, that's fine. But if it is not, this is not the time to learn to do that on these high-risk patients. I've mentioned getting the equipment right for the patient when they're coming into theatre, so having a range of tracheostomy tubes and bringing this special specific inline suction set, which I'll come on to shortly. If they need other additional procedures, then this is the time to do it because they're in theatre, so get those all organised in advance. So that's to do with logistics. And when these patients are being brought, ideally we felt that perhaps they should be sorted out 30 minutes before we send for them. But that, again, is sometimes wishful thinking because ITU are usually stretched and may not be able to offer you that support. So this is the inline suction device that I talked about that you have attached and ready so that when you're performing your tracheostomy, this should already be made up because you don't start making this up at the end when you've already got the trachea in because it does take a bit of a while to connect all these pieces together. And the aim is that the tracheostomy will attach here and you can use this sealed off closed suction to suction into the trachea. And the other good thing about it is that this concertina tube is collapsible, so you can clamp it as well to stop aerosol escaping into theatre. So this is a list for what the anaesthetist should have. I won't dwell on it for too much, but they do need to have all their equipment. And what we felt was particularly important was having the Yanker sucker taped so that the sucker is at maximum efficiency as you're trying to clear secretions from the pharynx and you don't want to be exposed to any aerosol in that process. They should have a video laryngoscope as well. This is really important because we don't want them to have face-to-face contact with these patients. So keeping that at a distance is ideal. And then obviously the usual with protection of the eyes, taping the various endotracheal tubes to their various sets is also important. And I'll come on to that shortly maybe. Performing the tracheostomy, I've already mentioned, but one or two things that we did change, obviously protecting the patient and preparing them and draping them and putting them in the position is similar. But for the drape, instead of putting a head towel, squaring the neck off so that you have a tape going across the chin and over the sides of the patient and onto the operating table. But in order to avoid sticking down onto central lines and to the endotracheal tubes, putting an Inco pad, which was suggested by Jay Ahmed, I think is a very good idea because you then have an extra layer of material that stops everything being stuck down and pulled off when you're at the end of the procedure. Do tie off any vessels that you see, transfix the isthmus. You do not want to have to go back in and deal with these patients. So if your usual practice is to just bipolar or use some form of powered instrument, which we shouldn't be using anyway, because there's a risk of aerosol generation, then stick to the straightforward and standard techniques. I also put in a bit of local anesthetic just to reduce skin bleeding and have a reasonable size incision, not super enlarged, because then there's more to close at the end. When you're doing the procedure, the patient should be pre-oxygenated and paralyzed before you cut the window. So you have to start warning your anaesthetist that you're near to that point. And obviously have the equipment already in set. As I've already described, particularly the inline suction catheter. When you're ready to cut the window, you have to ask your anesthetic colleague to blindly move the endotracheal tube with the cuff inflated down towards the carina so that they are still ventilating the patient, and they might then be aware if they've gone in too deep because the machine might tell them that pressure requirements have gone up, or the patient might desaturate. Hopefully they won't desaturate that quickly because you'll have pre-oxygenated them. Cutting the window, you might decide at that point to put in a tracheal stay suture if that's your practice. In our unit, we have OMFS colleagues who like to do that, and so ENT have been asked to follow the same protocol. When you have made the tracheal window, they have to stop ventilation because there is a risk of aerosol coming from the lungs across your face. And you ask them to open the APL valve, which is one of their return valves, so that there is complete loss of any intraluminal pressure, so that if the cuff is punctured or if there is any other problem with the circuit, when you make your tracheal window, there is no chance of an aerosol being jetted through the first cut of your tracheal window. Once that's all done and you're happy with your state of play, you might then do one of two things. You might go straight in to put in the tracheostomy tube, in which case you have to get the endotracheal tube withdrawn. Or it may be that if the patient is slightly brittle, you might need to resume ventilation. If the cuff is intact, you can just withdraw the tube and have the cuff seal your tracheal window, and that's fine for ventilation. If the cuff is down, you might then put a saline or betadine-soaked swab over the tracheal fenestra and then decide on what you're going to do next, which for me would probably be just to get on and put a tube in. So you might opt to put the tracheal rescue suture in at this point after the window has been created. You might ask for suctioning of the pharynx so that there's no more secretions to go down into the trachea whilst you're doing the next step of withdrawing the endotracheal tube and then putting in the tracheostomy tube and securing it. Once things are in place and you've got your anesthetic circuit connected to the tracheostomy tube and you're confident that the cuff is holding, get them to ventilate, look for CO2 trace, check that there are chest movements, and save your colleagues unnecessarily ruffling around under the drapes to look at the patient to see if they are adequately being ventilated. And then standard securing of the tracheostomy, we're using silk sutures and the tape, as I've mentioned previously. You still have to help your colleagues to get these patients off the operating table onto their bed, and then so they can be safely taken back to the ward. So they need to clamp the tube when they're changing from one ventilator to the other ventilator. And that is on that concertina bit that I showed you previously. And then once they're on the bed, they can then be safely sort of sent back. You haven't finished the procedure until you do the things that I've outlined here. And I think these are as important as putting on the PPE. We know that this virus has got that biphospholipid layer, which is essentially a bit of fat and a bit of protein. And soap is very good at getting rid of that. So after you've doffed, you should at least wash your hands and if you need to, your face, if you're worried about that. And definitely go and have a shower at the end of that theatre session. And in our trust, they give us the appropriate sort of scrubs and shower pack that we can take away in a plastic bag and then dispose of our scrubs in an appropriate manner. And we, just to finish off, we use a tracheostomy passport, which adds a layer of safety so that the ITU team know what the tracheostomy is, what the grade of intubation is, and so on. I'm going to stop there. I think I've overran. But Jay can tell me if there are any questions.
Actually, we've got the permission to carry on if you wanted to. It's unlimited now. So,
how much time do we have? Because the next part of the talk is basically pitfalls and complications.
So, I mean, without causing fatigue, if there's anything more on the COVID scenario, probably we could save that one for another session. Yeah.
I'm happy to stop here. That's why I put this note to break.
So I think there probably will be lots of questions and some very, very topical questions. So I'm just going to go through some questions that people have asked straight away. Which hopefully you can answer. So why the third and fourth tracheal ring? Just for the juniors.
Okay, so that's the classic description of a tracheostomy. Third or fourth tracheal ring is ideal because you're well away from the cricoid. And in the old days, if you put a tracheostomy in the first tracheal ring, there's usual migration rostrally of tracheostomy tubes. And you'll see this in your patients who've had a tracheostomy in for more than a few months. There is a rostral migration of the tracheostomy. And that means that the next point of contact will be the cricoid, which is the only complete ring of cartilage in the whole of our airway. And if you excite soft tissue reactions there, you will definitely create subglottic stenosis. So why do we say the third or fourth tracheal ring? Because that's the ideal. And so we're teaching you the ideal, and that's the gold standard. But if you are in a difficult situation with a short, fat-necked patient whose cricoid is at the level of the suprasternal notch, you may be lucky if you get it into the second tracheal ring, but at least try then for the second ring.
Okay, thank you. Another question. What method of penetration into the trachea do you use? I know there are various methods have been described, and what are the advantages and disadvantages of them, do you think?
Penetration as in cutting the window?
Cutting the window, slits, vertical, cross, flap.
Okay, so there's a whole host of different things that people have done over the years. My own personal preference now is to cut the smallest possible tracheal window, less than 1 centimeter, and it's only on a single tracheal ring, and then making 2 horizontal incisions either side of that window on that tracheal ring, so that the 2 flanges of the tracheal ring that have been cut are able to open.
Sorry, that's probably my Amazon parcel coming.
Shocking. Okay.
Hang on 1 second.
Bjork flaps. Some people ask about Bjork flaps, which is where you have a little bit of the tracheal tissue attached, usually to the lower tracheal ring, which is intact. And the reason for that is that some people believe that this would allow you to to replace that tracheal window once the tracheostomy is out, and reduce the risk of tracheal stenosis. And you can get tracheal stenosis if you take too large a window from the trachea. So Bjork flaps have had their problems, and one of the problems is that the springiness of that bit of tissue means that occasionally, if the sutures that are holding it on the inferior aspect of the flap fail, and the patient for some reason loses their tracheostomy tube position, then it may block the entry into the trachea for that reinsertion of the tracheostomy tube. So there have been some deaths associated with that, and that's the reason why people don't use that so much in the UK.
Okay, so another question. The front of neck axis, I think the Airway societies have advocated cricothyroid entry. Is that something that might be considered? And what's the safest way of doing it?
So the cricothyroid is a very easily palpable area. So you know where the Adam's apple is in males particularly, and you can feel that notch of the cricoid. And just above that notch is where you stab to get into the airway. Obviously, if the tumor or the obstruction is below that, that's useless. But if it's above that, then it does provide you with a stopgap, but it is only a stopgap. There are 2 arteries either side of the midline, so-called cricothyroid arteries, which probably come off the inferior thyroid artery, and they do bleed quite prolifically. And if you stab them and the patient starts then coughing across that, they can beautifully aerosolize blood across your face. So I wouldn't recommend that unless you've got the appropriate tube to put in almost straight away.
Khalid, I just want to ask one question. I mean, closer to home in our own practice, what do you feel about debulking tumours, particularly with laser or more powered instruments in this era or this time?
So there was a lot of guidelines that were put out there at the beginning of this crisis, and I think we have to be a bit more pragmatic about how we manage patients, because we're still going to get patients with tracheal stenosis or with large, massive supraglottic or transglottic tumours, and they will need some form of definitive airway management. And if you put a trachea tube into those patients, you might be compromising them. So if you can, use a laser, and what we have been doing here at the London and elsewhere is to use dual suction. So you have a jetting needle, but you're no longer using jetting technique. So you use that to suction, and that attached to a plume sucker can help to remove much of the aerosol. And then with your usual suction apparatus, you can have dual suction within the lumen of the laryngoscope. So you can then safely laser debulk patients. I don't think jet ventilation techniques should be used because you're still aerosolizing, so that should be avoided. So a small laser-proof tube, if it can be put in, would be ideal. What we have done for those patients where our anesthetic colleagues are worried about viewing the larynx is we have gone in or I've gone in and looked at the larynx up front with our own standard laryngoscopes, and whatever laryngoscope you're used to using, you should use. But for me, the best laryngoscope is the Dido laryngoscope, and that will give you, in more than 95% of patients, a view of their larynx. And with some suspension and some cricoid pressure, you'll get a view. And that will give you a chance then to intubate the patient, get them stabilized with a cuff up, and then you might then do an exchange and put in the appropriate tube over a bougie once you've got that. So there are different techniques, but that's, again, outside the scope of this talk.
Okay, couple of other questions. So in terms of indication for tracheostomy during the COVID period, I mean, we're actually advocating trachees to be done at a much later stage than perhaps might otherwise have been the case for non-COVID prolonged ventilated patients. One of the advantages is that, as you mentioned, to try and hopefully see if they can get better by themselves. And also the second advantage is to do this thing of proning the patients, which is almost impossible with a tracheostomy in place, and that's been shown to be helpful. There are a couple of trusts, and one close to us is Harlow, who are advocating doing trachees very early on, within a day or two, as a matter of routine. What are your feelings on that, and do you know anything, or does anyone? I'll open it to the
well, I think we don't really know is the honest answer. They claim that they're getting really good results, but I don't know what that means, because the reason that these patients die is not because their endotracheal tube has failed, it's because their lungs have failed or they have multi-organ failure. So how does putting in a trachea early help that? I don't know. Second, as you have correctly pointed out, when you're proning these patients with an ET tube coming out of their mouth, you know that it's in place. But when you have them proned and that tracheostomy tube is now buried by the patient, you don't know whether it's been dislodged, moved over, and much of the dislodgement that does occur with any trachea occurs within the first week when the tract is not mature. And even at a later stage, you can still dislodge a trachea tube and have a false tract form. So I don't know how they're doing it and what the rationale is, but some of those trachea patients will die. And that means that patients and theatre staff will have gone through an unnecessary procedure with additional risk.
I guess we have to watch the space, because I was speaking to our ITU department and they're watching that ITU department with a lot of interest, actually. Okay, so I think I'll just quickly answer some of the questions, other questions which are straightforward. Yes, so someone's asked, do we need to put bigger trachea tubes than normal to minimize a leak? And I think probably yes.
I don't think you would put a large tube in, because what they did in some of the hospitals, they've felt that they needed to put larger tubes in because these patients might run into difficulties if they keep the tubes in for long. And that was on the basis of China and Italy both avoiding tracheostomies per se. So in order to circumvent endotracheal tubes getting blocked, crusted, and so on, they put larger tubes in. But what that does, it puts a pressure on the whole of the laryngotracheal airway and causes stenosis. You put a size appropriate trachea tube in. You don't the next part of my talk was about sizing the tube and making sure you get the right size. And maybe I'll just show you that. You don't look at the sex of the patient to decide what size tube they get. You look at their height. It's well known that the tracheal diameter is related to the height of the individual, not their sex. And this is the biggest problem that we face as laryngotracheal specialists, dealing with tracheal stenosis, because people have had the wrong tube put in. So yes, you put in the right size tube for that patient. You don't err on the side of a small tube, but you don't err on the side of a big tube, because you're going to cause greater problems for that patient.
Thank you. And finally, percutaneous trachees. The pros and cons. What are your feelings on percutaneous trachea, and how are people doing it in the COVID era?
So I have no experience of COVID-related perc trachees. You can do perc trachees using suspension laryngoscopy or flexible bronchoscopy techniques. But if you're not familiar with doing that, and the audience that I'm talking to, I presume, are heavily surgically orientated, they will have been taught how to do a surgical tracheostomy, not a perc. So if you are doing a perc and you're using an open tract technique, there is a risk of some aerosol coming up at you. It may be that they might withdraw their endotracheal tubes with a fibroscope down the lumen of the tube and then getting it in the right position and then putting the needle in and so on. Or they may be using a blind technique, which is what they started off with in the mid-80s when this technique was first started by Siagler. But I wouldn't be advocating doing any of that, because if you have not done that before, this is not the time to be doing it.
Agreed. And actually, some of the teams that are doing perc trachees are doing it blindly, like you've suggested, because of the risk of aerosolization in the setup of.
Again, the second part of my talk would talk about all the complications, and everything is very close to everything else in the trachea and in the thoracic inlet. So a slip in the wrong direction and you could be in some serious trouble, or the patient could be.
Lovely. Thank you very much. I think that's just about all the answered everyone's questions. So I'd like to draw this talk and this lecture to a close now. I'll probably hand